Good afternoon and welcome. My name is Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School, and I'm delighted to be here today with Bisola Ojikutu, who is the Commissioner of Public Health for the City of Boston and also a Harvard Chan School alum, class of 2003?
Yes.
All right, very good, very good. Thank you for joining us today. Last year, your commission put out Health of Boston and talked about this gap, this 20-year gap in life expectancy based on where you lived. Mm-hmm. Is it Back Bay or Nubian Square, and even differences in life expectancy by race, ethnicity group. Mm-hmm. It's not new having this gap in life expectancy. Can you talk a little bit about what has changed from when we looked at this, say, 20 years ago to when we looked at it now?
Mm-hmm. No, absolutely. First of all, I'm honored to be here. And it's so good to see you, Dr. Reed, and honored to be here talking to you all. So the original data that showed the 33-year life expectancy gap was really looking at the difference between the census tract in Roxbury and one in Back Bay. And that data actually came out in 2012, so it was quite dated. And when I started in my role in 2021, I looked at it and said, wait a second, something has got to have changed by now. So let's interrogate this data, let's get some updated information, and then let's figure out what to do next. So we worked with a VCU, Virginia Commonwealth University, and some folks even around here at the Harvard School of Public Health, and we updated the data. And what we found is that instead of a 33-year life expectancy gap, there was actually a 23-year life expectancy gap. And I want to emphasize that we talk a lot about this gap, and there's been a lot in the media about that difference between 2 miles difference between Roxbury and Back Bay, but there are actually these pockets of relative disadvantage around our city. So we're talking about Dorchester, we're talking about Mattapan, we're talking about JP. We also have an area in Alston-Brighton that has a lower life expectancy. So it's not just Roxbury. So we said to ourselves, okay, let's take this first difference and see, was there something that changed between 33 and 23? The reality is that there was a lot of activity that initial 33-year life expectancy gap. I think you wrote something on it. There were a number of people who wrote about it, and there was a groundswell of community activity that went towards, okay, let's do something. Let's invest in community. Let's build up capacity of the community health center. That was a partial contributing factor, but there's also gentrification, and there are demographic shifts. There's the reality of the data. As you look at the data that you create, think about why it's actually happening. So I say all that to say we have a lot of work still to do.
Absolutely. And as you think about this work, can you tell us a little bit about what you came out with this Live Long and Well, and how does that relate?
Okay, so data is important, and I'm very much so, as you can tell, interested in data and data points, and surveillance is a primary thing that we do in public health, but you got to act on it. You have to take that data and then move it into action. So what we did is we said, what is it that's actually causing this gap? Okay, both upstream and downstream, what is it? And so we did a decomposition of the gap. That basically means looking at the gap and seeing what is it in terms of the age groups, in terms of the racial, ethnicity, what is it that may be different about these individuals that's causing them to have this gap, and what are the disease entities. And when we did that decomposition, we found that there are really 3 top causes. That's 3 reasons that we have this 23-year life expectancy gap in that particular, between those 2 census tracts. It's number 1, substance use disorder and overdose mortalities. Number 2, heart disease, cardiometabolic disease, and preventable cancers is number 3. So those were the 3 things. So we said to ourselves, what are we going to do about that? Because we're already doing a lot. So one of the things that we're not doing enough of, unfortunately, is that we're not looking at upstream factors, the factors that really drive life expectancy, that really drive premature mortality. A lot of our work, as we know in this very resource-rich city, is focused in on healthcare. And be clear about this. We all need to be clear about this. Health inequity doesn't begin or end within the walls of a healthcare institution. Okay, it really begins or ends within our communities. So we said to ourselves, what are the things in our community that have not been well addressed? So there were a lot of initiatives about housing. As you know, Mayor Wu does a lot, and Governor Healy does a lot about health inequities related to housing problems. We've done a lot with transportation. We've done a lot with some of these upstream factors. But one of the things we haven't done enough with is with economic mobility. Okay, and so we basically went out and we shopped an idea to a number of different foundations. We found collaboration with Atrius Health Equity Foundation, and we were already leading the Boston Community Health Collaborative, which is a group of community folks who basically said that economic mobility is where the money is. That's what we need to fund. Atrius gave us $10 million, and we are moving that forward to look at strategies that will actually put money in people's pockets, change their trajectory, and hopefully address some of these downstream outcomes that we really want to address, particularly as I said, premature mortality and life expectancy differences.
As you talk about this, and you talk about the community health collaborative and how that brings the community in.
Yes.
Does this also address part of the siloing of some of the departments or areas within the city itself that could have an impact?
Absolutely. And not only that, of course, it does bring together siloing amongst our city agencies, where we're not really thinking about how transportation, built environment, housing, and all of this relates to health. But what it's doing is it's bringing the silos, breaking down the silos in our healthcare system, because we essentially have representatives from all of our major healthcare organizations, as well as our community health centers within this group. And, I think a lot of you all probably have heard this in the media. What we have here is a situation where we are resource rich, particularly in regards to healthcare resources, but we aren't so collaboration rich. We're actually collaboration poor in many ways. So this group brings us all together in the same space. We do a community health needs assessment, which is actually out in the field now. You can actually take it, tell people, your patients, if you have patients, people in your community, to please take it. This is how we get the information to know what the needs are, and that's how we got to economic mobility.
So as you think about this and this coming together around the Boston Community Health Collaborative, I know both you and I have been involved in the Health Equity Compact,
yes,
which is another. Can you talk a little bit about that, and how does that relate to what you're trying to do with the city?
So I think this is a great moment in time in Massachusetts. It's a great moment in time in our world, irrespective of what has happened recently. It's a great moment in time because we have numerous leaders of major organizations, major institutions who are people of color and who are focused on equity. And so the Health Equity Compact is it's a collaborative effort amongst 80 plus leaders of color who are essentially individuals who are moving organizations forward. They're moving and shaking things in many ways. And I think that one of the major pieces of that is that the purpose of the compact is to really think about how can we harness our collective impact? How can we amplify our voices as leaders? What is it about our presence as leaders makes a difference in what's going to happen? And so that's the Health Equity Compact. So I think that one of the reasons why we're talking about this here is because it really is about collaboration and partnership and building strength. And that is what is moving things forward. And it relates very much so to Live Long and Well, because all of them are part of that initiative. We're all working together on this. And I think that's what we need to do. It has to be sort of an all of society and all of government, you mentioned, but all of society, all of leadership approach if we really want to change things in regards to health equity.
And coming together, and in some ways voices that you might not normally associate with issues around health and the critical positions and in leadership. With that in mind, can you talk a little about the importance of that representation in leadership?
I think that it's incredibly important to have people at the table who, look like the populations that they're serving. I think there seems to be, a recognition of that fact, right? I hope that there is. But what I would say that for me, if I just take this back to my own journey, I lived health inequity. I grew up on the south side of Chicago. One side of an invisible line was prosperity and the other side was disadvantage and actually despair, And I knew from a very early age this is something that I wanted to do. So as I moved forward and I decided to go to medical school, I looked around for examples of people who were doing the things that I saw and I thought that would move us towards advanced health equity. And one of the people who I saw doing that was Joe Betancourt, who's the president of the Commonwealth Fund. And he was actually the person who introduced me to the Commonwealth Fund Fellowship and introduced me to you, Dr. Reed. You probably don't remember. And I was like, wow, look at him navigate Cornell, because that's where we did New York Presbyterian Hospital. That's where we both did residency. Look at him navigate this space and really move forward with this idea that disparities aren't right, they're unjust and unfair, and we must have diversity in these spaces. And I used that example, and I said to myself, I really want to be like him. So I ended up applying for the Commonwealth Fund Fellowship, and that's how I felt launched a lot of my career.
Very good. Thank you. Thank you for that. As you talk about this work that you're doing and the collaborative and the work you're doing in these three major areas, would like to know more about them. But there's another area that is in the news almost every day, and it touches on mental health and behavioral health.
Absolutely.
Critical issues for our community. And could you talk about where the city, what is it doing in that space?
Absolutely. I'm glad you're asking me this. So prior to me taking this role, I had a conversation with the then Counselor Mayor Wu. Well, Counselor to be Mayor Wu. She was still running for mayor, and we were talking about our collective sort of interest in what it is that we wanted to move forward. And obviously, we were in the middle of COVID, so it was 2021. But one of her major priorities was youth mental health. And we both, said, we've got to do something about this. And I remember saying to her, well, we need a youth mental health initiative. And she said, Dr. Ojikutu, go sit and think about that for a bit. Do we need an initiative, or do we need real systems change? Do we need structural change? And so I sat around with my new team and I said, what is it that we need to do? Well, number one, let's figure out where the money's coming from. And so we were able to come together with other entities, and we came up with $21 million. We said we have to change our structures here at the Public Health Department. It can't just be that we have an initiative. That's transient, as we all know. That's something that can come and go, depending on the money. We need to embed this within our city funds. We need to make sure that we're getting this money on a regular basis. We need structural change. So we created a Center for Behavioral Health and Wellness, and we did that in 2022. We said, this is going to be an entity that works across government, across the health departments, and across the health institutions, and with academia. That's why we sort of use the center term. And we said, we're going to get a chief behavioral health and wellness officer. We're going to get somebody in here who's an expert. And that's actually Dr. Simon, Dr. Kevin Simon was also a Commonwealth Fund Fellow. And so we recruited him. We said, let's open this office and let's make sure that we get this money on an annual basis, so that when this initial $21 million investment runs out, we will have money on an annual basis to move this forward. And so what we focused in on is this issue of diversity, and actually increasing the pipeline of people who are invested in and able to provide mental health services, particularly to young people, and get them to stay here in Boston. And we're working very closely with Boston Public Schools, creating a trauma-informed school district. So actually putting the information, the training, the people there who actually understand trauma, who understand anxiety, depression, who understand emotional dysregulation that's occurring. I know Dr. Reed is a pediatrician, and we're having some troubles in our schools and amongst our kids. And that is a lot of the work that we're doing right now.
The trouble is not just with our kids.
Yeah,
but
I know.
I'm just saying. Just saying.
That's
putting
true.
it out there.
Let's not put it all over the kids.
Okay. There's a piece of this as you talk about this concept of initiative, which can be short-lived, versus really systemic and structural change. Can you talk a little bit about this Live Long and Well and this Community Health Collaborative and the Health Equity Compact? Is it important to make it so that these are not initiatives, but actually lead to systemic change?
Absolutely, absolutely. And I think that is a lot of how I've been framing it with my staff. So we have about 1,300 staff, and they're all sort of behind this Live Long and Well, and they're all aware of what we're doing with the compact. But I think that one great way to think about this is, how do you change policies, laws, legislation, regulation to make this long-lived? How do you embed what we're doing in the structure of how we exist as a health department and as a city? So one of the things, I'll just give a few examples. One of the things that we're doing with the Health Equity Compact is we are moving forward with a bill that was written by a lot of us on the Health Equity Compact called an Act to Advance Health Equity. And so this bill is currently being discussed in the state legislature. And I think it's important because what it's saying is a number of things. It's a big omnibus bill, but it's saying a number of really key things. One, let's embed equity and the drive for equity within state government. So let's have somebody who is in charge of equity. Now, one may say, okay, but that's one person, but let's put the money behind that and let's actually put it within offices. Let's share data, because that's a huge problem. We don't even know when a problem exists, oftentimes, even in this resource-rich city of ours, because we're not sharing data across our institutions. And then let's also say, you know what, we have to promote diversity, equity, belonging, inclusion in the pipeline. We have to make sure that people are able to get into this pipeline because we know how important it is in terms of health outcomes. So then what does that mean for public health? Because when I joined, they were really talking about healthcare equity. So within the walls, everything I said could be construed to be within the walls. Some of us were public health oriented people, and we said, wait a minute, we got to talk about social determinants of health. We have to talk about what's in communities. We have to talk upstream, what's actually happening out there that's actually driving a lot of what you're seeing by the time end stage, by the time it gets to your door or to your emergency department. So one of the components of this particular bill is the formation of health equity zones. Now, health equity zones, these are areas that are identified as having challenges. Most areas, but if you were to look at here in Boston, it's a lot of these areas with lower life expectancy. And what you do is you put the money in to these areas, do the type of investment that counteracts the disinvestment that's been going on for decades. You put the money in the hands of people with the lived experience, the people who actually live in those neighborhoods, and you let them decide what it is that they want done. If you're talking about economic immobility, well then, okay, we need to do something about our businesses. You know, we need to do something about our workforce development. We need to do something about our education. We need to make sure that our parks aren't strewn with trash and so on and so forth. All the things that we know make for the context of health, make for a better health ecosystem. So that is also in the bill. So it really is a broad-ranging bill. If it moves forward, that is a structural change that I think is really important. And actually, I was talking to the commissioner, the acting commissioner in New York City. They would like to move forward with something like that also. So it's something that really is having a national impact.
Wonderful, wonderful. You know, as you talked about these three areas that are going to get the support with this Atrius funding. And can you give a hint at what kind of things fall into that space as you talk about cancer, as you talk about heart disease, as you talk about substance abuse? What is the thinking about what we might be able to do in those areas?
So I think broadly, as I mentioned, it really is about thinking upstream and economic mobility. And if you think about the things that one could do in economic mobility, is it cash transfer? Is it about universal guaranteed income? Is there something that we could be doing more robustly to ensure that people have the ability to move from sort of one position economically to the next? And then if you're thinking about multi-level interventions, could we pair that upstream with some downstream work? Like, could we partner with community health centers and have people who are either at risk for cardiometabolic disease, have one of the preventable cancers, have some other disorder that we think is relevant to this, as I've mentioned, and say, let's provide them with the right package of services, not just the things that we're doing now, and I shouldn't say just, but a lot of the sort of meeting the social needs of patients. That's oftentimes a one-off thing. It's a transient thing. Really thinking bigger picture. How do you address these needs community-wide? So that's what we're thinking about. We actually have an RFP that will be released in December. This is an RFP that's coming out of Atrius, Boston Community Health Collaborative, and the Boston Public Health Commission, looking for community-led collaborations. So these are things that you can think about as you're thinking about how to work with community to do things that are upstream, that are multi-level, working with healthcare, and can also have a downstream impact.
What I hear so strongly in that, and it's particularly as we think about the community and where this is being held today, it's how we can work with community as opposed to what is it that we want to do to or for or about community, but led with community. So wonderful opportunity within that. You've had an interesting journey. You've talked to us about where you were born and its influence on you. And you've talked about you're actually coming to the Commonwealth Fund Fellowship, to the School of Public Health. What happened after you left the School of Public Health?
Yes.
And your journey to where you are today?
So when I talk to students about my career, I oftentimes say that it's somewhat circuitous. And I don't say that to be negative. Those people have said that in a negative way to me. You know? it's not negative. It's made me a better leader. That's what it's done. Immediately following the Commonwealth Fund, I actually ended up moving to South Africa because at the time, PEPFAR was rolling out and money was flowing into various parts of the globe. And I was very much so interested in HIV. I spent a lot of time when I was at Hopkins in medical school in our AIDS ward and just really saw HIV as the end stage of all these ills that we're talking about. I mean, if you really think about all that's happened in a population being made vulnerable, particularly Black and brown individuals. So I went to South Africa, I lived there for a while, and I helped essentially implement PEPFAR-related work in Durban. And that meant, from my vantage point, what I was trying to get out of it is seeing how you take big policies and it trickles down to the people or doesn't. And watching that, it was really an eye-opening experience for me because I was able to work with the Ministry of Health, plus work in clinical settings, plus work in communities over time, and really understanding what was and wasn't working. And hopefully make some change and have some impact. But I felt like it was more impactful. They were giving to me more so than I necessarily at that stage of my career was giving to them. But what I realized was just, you have to see what's happening elsewhere in the world. And for those of you who have not, I would say pause and take that opportunity. I ended up actually, from there, I did come back to the US and finish my infectious disease fellowship. I did a lot of back and forth work, training providers in HIV care and treatment. But what I ended up doing was spending the next decade of my career working throughout sub-Saharan Africa. So I worked in probably about 15 different countries, implementing large programs and trying to make it work so it was less of a trickle down. Trying to make it actually be a flood, and get the money, get the resources into communities in ways that I thought were really impactful. At some point, I did decide, mainly for family reasons, to be quite honest with you, that I wanted to come back to the U.S. So I came back. I ended up becoming an assistant professor at the medical school and got a K award, really looking at the structural barriers to HIV treatment prevention here in the U.S. And it was at that time, probably I was maybe year 4 in my K, maybe year 5 in my K. I was looking at independent awards. And at that point, COVID hit. And I had, because of the work I was doing in my research, it was action-oriented research, so I was out in communities. It really positioned me in a way that I knew people and understood how things worked. And I was brought in to consult on various different projects related to COVID-19 and COVID vaccines. And I was offered this position. So it wasn't intentional. I didn't say to myself, oh, I want to be a commissioner necessarily. And I wouldn't even say that that's the way to look at things. It really can be a leader in any sort of way. It was really me just doing what I felt was right and what my heart told me to do.
And taking advantage of opportunities.
That's right.
And recognizing opportunities when they're there. The other part I would say in this is, as you describe what you've done, there's a part of going elsewhere to learn and to experience. But sometimes elsewhere doesn't have to mean you leave the country. There's elsewhere where you can actually be in the country and experience some of these types of things. Now, as you have done this, and I know you care deeply about the people that report to you, the people that you advise and mentor and guide, and have talked to some of them and talked about the importance you have made in their lives. Can you talk about the role of mentoring or sponsorship for you in terms of this journey that you've just described?
I don't think that anybody's journey happens in a way that, that puts them in spaces that they need to be in if you don't have somebody guiding you, irrespective of who that person is. And it doesn't necessarily have to be the same person throughout the entire journey. It can be a whole group of different people. And it could be people that, you're watching from a distance, you may talk to, every now and then. But there's something about mentorship. I look at it broadly. I really do. When you say I've taken advantage of opportunities, it was largely because people told me that these are good opportunities. You know what I mean? And it wasn't because I inherently knew that this was the right thing. When I was leaving the Commonwealth Fund, I remember I spoke to you. We were talking. You probably don't remember. You've mentored so many people. But I remember I was talking to you, and I had this opportunity. I could have worked with Paul Farmer at the time. I could have worked with Max Essex at the time in Botswana, or there was this opportunity to go to South Africa. And you were like, so what speaks to you about each of those? I mean, those are varied experiences. And it was really the fact that I sat down and I thought to myself, I could go to the country that is so inequitable within the country, with the highest rate of just economic inequities ever. And I could see that firsthand, and I could see how this works. And I have this opportunity, and they're going to let me decide. It wasn't prescripted, the actual role. And I said, okay, I don't really know exactly what I'm doing, but it was really feeling motivated by you and by the opportunities that you laid out within the Commonwealth Fund Fellowship. I mean, really, it's the people who you exposed us to, and just kind of talking to them, hearing their journeys, thinking to myself, well, I can do that. These are things that I can do. And so mentorship, I think it doesn't always take the forms that are scripted anywhere, but it's really powerful. So I would look for people who you admire. Like I said, watching Joe navigate, and even now we're meeting next week to talk. These are all people who I look to and really think about, when I have something that's on the table, that's a new opportunity, that's a pivot, I say. These are the people I text. I start texting people, and I have a whole list, and I look at them as my mentors.
There's you, and thank you for that. As you well suspect, not much guidance was needed. She knew where she wanted to go. All right, not at all. But I want to talk a little bit about that, because oftentimes we have self-doubt, or we wonder, am I ready, or am I right? Can you talk a little bit about that, because you have stepped into spaces where you didn't know what exactly you were going to find, and what was it about you that enabled you to do that?
Wow, that's deep. It's been interesting, and it's been an interesting journey. There were times, like particularly when I left here to go to South Africa. I hadn't been to South Africa. My father is Nigerian. We traveled through Nigeria before, but I'd never been to South Africa. They said, pack up your stuff and go. And so that was a big leap. And then the work that I was doing following that throughout sub-Saharan Africa, oftentimes I was getting on a plane and ending up somewhere that I had no idea where I was going, but wanting to have an impact. And then even taking this role, Commissioner of Public Health, where it's like 1,300, 1,400 employees, I have not managed that many people before. I'm just telling you honestly, I had not. I'd managed hundreds of people when I was doing the consultancy work around the world, but not 1,300 people, and not the wide array. I think that within me, there's this element of, well, I'm going to do the best that I can, and hopefully they'll appreciate me for who I am. And I have to say that may sound, naive or something, but it really isn't. It's me saying to myself, I think I have something to bring to the table. I think I've watched enough people, and I've talked to enough people, and I have enough people in my text, in my contact book, that I can ask them, and I'm just going to go there and do it. And if it doesn't work out, there's always something else that you can do, but you have to take that risk. And oftentimes when I'm talking to students, there tends to be this risk-averse thing that comes along. Sometimes I have to say in academia, different from, because I've talked to a lot of different students, young people in different areas. But, when you are in academia, I'll just speak to my own experience. There was a pathway. Okay, get your K, get your R, get your this, move it along. And there's less risk if you follow that pathway. If you start to deviate, if you start to move in different ways, there's more risk. And I think I always told myself that, it's okay if there's a risk, because if it doesn't work out, that wasn't where I was supposed to be in the first place. And to be quite honest with you, I am well educated, and I will find something else to do. But I will know that I put my best foot forward, no matter what it is that I get myself into.
That I would add is that you're prepared. Okay. And so sometimes we can block ourselves because we think we need more and more and more preparation. That's true. And you are prepared. And the other part I'd say watching you is to have the kind of impact you want to have, you don't want to do what's already been done.
Yes. That's
and
right.
so how do you step in a different way, with a different lens? And if I look at part of what you've done with Live Long and Well as you stepped in, what you did during the pandemic in the city of Boston, these new collaboratives and the compact and pulling community together, I see you taking all that you have learned and you've prepared for this moment in time. This moment
Thank
in
you. I
time.
appreciate it.
And what I would say is I look at you in your journey in thinking about, am I ready? Is that you have always been enough in terms of what you bring to the table.
That's good to hear.
And so I thank you. I thank you for the work that you are doing and will do. I thank you for caring, truly caring, not just about patients, but about community, about individuals, about creating real change, sustained change, structural change, as you talk about there. And thank you for this conversation today. We're going to be saying goodbye to our online audience, and I want to thank you for joining us. And if you missed part of the program, you'll be able to view it on demand at Harvard Chan School's YouTube channel. This has been wonderful. I'm going to tell you, there's nothing more joyful than watching somebody you saw at one point in your career 20 years later blossom into like something big.
Thank you.
And thank you very much.